Thank you very much. I'm Jim Kirkland. I'm going to talk about geroscience and its application to aging and chronic disease with respect to development, particularly of interventions that target fundamental aging processes. By way of disclosure, I have been involved with a company that develops senolytic agents, but I'm not involved in that company at the moment, other than continuing to hold some shares in it. So the geroscience hypothesis, which dates back from around 20 years ago from Gordon Lithgow's work, holds that fundamental aging processes, what we call the pillars of aging, may be root cause contributors to a number of conditions that are associated with old age, such as the geriatric syndromes, things like frailty or mild cognitive impairment or immobility, but also chronic diseases in younger individuals throughout the lifespan. Because fundamental aging processes begin at conception, and the notion is that they might operate at sites of pathogenesis of multiple chronic diseases, including things such as the dementias, cancers, atherosclerosis, diabetes, and so forth. For a number of these conditions, chronologic age is by far the biggest risk factor. For example, the risk of getting Alzheimer's disease can be 80% predicted by age alone. But there are other groups that get Alzheimer's disease much earlier. And these individuals, it's turning out, have earlier operations of some of these fundamental aging processes at the sites of brain pathology. And then fundamental aging processes may predispose to decreased physical resilience, that is, decreased ability to recover after an infection or after surgery or after, say, chemotherapy. So fundamental aging processes you can divide into anywhere from 4 to 13 groups or more, the so-called pillars of aging. I like to think simply and divide fundamental aging mechanisms into 4 groups. These pillars appear to be very interrelated. What we call the unitary theory of fundamental aging processes, such that if you target one of these processes, you tend to affect the rest. But in general, in older people at sites of age-related changes, and in younger people, including children, at sites of pathogenesis of chronic diseases, one of the things that occurs is inflammation. And this inflammation is low-grade, it's chronic, it occurs in the absence of known pathogens, and is associated with tissue scarring or fibrosis. The second group of processes involve macromolecular and organelle dysfunction, things like problems with DNA, with proteins, with formation of protein aggregates or failure of protein removal, problems with sugars, including formation of advanced glycation end products, problems with lipids, including lipid accumulation, especially of saturated lipids and ceramides and and various toxic kinds of lipid-related molecules. And then dysfunction of intracellular organelles, especially mitochondria. Also stem and progenitor dysfunction and cellular senescence, which is a process I'm going to focus on. I'd note that a number of these processes tend to operate in the context of chronic infections, such as HIV, and after infections, such as with coronavirus. So cellular senescence is a process that can occur at any point during life from conception on, like other fundamental aging processes. It occurs across the vertebrates, and it's a cell fate, much like replication, differentiation, apoptosis, or necrosis. Damage signals can induce a cell to become senescent. Also, mechanical or shear stress can, and pathogens can induce a cell to become senescent, as well as drugs and reactive metabolites and repeated stress due to cell replication. So there are maybe 40 or 50 things now that are known to push a cell towards the senescent cell fate. A cell takes these damage-related or stress-related signals, integrates them, makes a fate decision whether to undergo programmed cell death or necrosis or senescence. And then if the senescent cell fate is what occurs, any one of 3 or 4 transcription factor cascades can be activated that eventually wind up leading to cellular senescence, which is a state of essentially irreversible replicative arrest. but these cells resist dying, and they're actually quite frequently metabolically active. It takes anywhere from 10 days to 6 weeks for a cell to become senescent. That'll become important when I talk about the clinical trials and drugs that target senescent cells a little bit later on. Some senescent cells have an upregulation in P16 and retinoblastoma, some P53 and P21, some both, and some neither. So one of the things about senescence is that there are redundant transcription factor cascades that can enforce this process, and there are no completely consistent biomarkers of senescence that are totally sensitive or specific. Some senescent cells, around 30 to 70%, can acquire a senescence-associated secretory phenotype, but it's 30 to 70% of them. Not all senescent cells necessarily do. And this senescence-associated secretory phenotype, or SASP, entails production of a range of proteins, peptides, bioactive lipids, reactive metabolites, non-coding nucleotides, exosomes, and other features that can cause local and systemic tissue damage and can also spread senescence. So the kinds of proteins and peptides that are produced include a range of inflammatory cytokines, chemokines that attract, activate, and anchor immune cells, and proteases that damage tissues. But not every senescent cell has a secretory phenotype like this. And the phenotype can vary depending on the inducer of senescence in the first place, the kind of cell that became senescent, and how long that cell has been senescent. And then various drugs can modify this state as well as hormones and the milieu. Senescent cells, as I mentioned before, are resistant to dying, and I'll come back to that, why it's important. But this is related to what we call SCAPs, or senescent cell anti-apoptotic pathways. So senescent cells accumulate in various human tissues in advanced old age. They can occur at they occur in different tissues at somewhat different times, depending on the individual. And in adipose tissue, for example, or skin in people somewhere between the 60s and 80s, there tends to be an exponential increase in senescent cell abundance. And this shows adipose tissue from relatively healthy older people who are kidney transplant donors. So by definition, they're pretty healthy compared to younger kidney transplant donors. And there's a takeoff in senescent cell burden in their adipose tissue somewhere in the mid 60s in many people. But senescent cell abundance is always low. Senescent cells can accumulate in younger individuals in the context of chronic diseases, including HIV. This shows senescent cell accumulation in obesity and diabetes in a younger woman on the right compared to a slightly older woman who is not obese and diabetic on the left. The senescent cells are being shown up here by senescence-associated beta-galactosidase staining. Again, that's not completely sensitive and specific, but it does show that senescent cells tend to, at least in adipose tissue, be associated with blood vessels. They include endothelial cells, perivascular cells, adipose progenitors, and other cell types. Transplanting very small numbers of senescent cells into younger mice, into middle-aged mice, can cause these mice to become frail, to develop an accelerated aging-like state, and to die earlier than mice that are transplanted with non-senescent cells. In these transplantation models, it takes only 1 in 10,000 cells, so that 1 million senescent cells are transplanted into the mouse. That means 1 in 10,000 cells in that mouse is senescent. And that's sufficient for these animals to have a reduction in their gait speed, their hanging endurance, their grip strength, and to die earlier than mice that are transplanted with non-senescent cells or with vehicle. So small numbers of senescent cells are sufficient to cause tremendous changes in function. And these mice that die earlier of all age-related diseases, not any one disease, but all of them. So there's an accelerated aging-like state, confirming that cellular senescence is likely one of the pillars of aging. If you if you label the transplanted senescent cells so that you can distinguish the transplanted senescent cells from the recipient's own cells, you find that the recipient's own cells start becoming senescent, both around where the transplanted senescent cells are, but also at a great distance. So senescence can spread in both a paracrine and an endocrine manner. Senescence was first described by Hayflick and Moorhead back in 1961. It was noted that senescent cell burden increases with age and disease in human skin in the 1980s. We noted that senescent cells increase in rat fat tissue in animals that are double barrier reared, cesarean born, and specific pathogen free, showing that this is an age-related process in the early 90s. An important paper came out by Ned Sharpless, who's now director of the National Cancer Institute, showing that an intervention, food restriction, that increases health span, the period during life when animals are living free and independent of chronic disease, that caloric restriction, which is known to increase health span, results also in a delay in senescent cell accumulation. And that led us to ask, is that just an association, or is there a causal link? So we began trying to develop agents that would specifically eliminate senescent cells back in 2004. We tried all kinds of approaches, got nowhere, and came up with a hypothesis-driven approach. We remembered that senescent cells are killing the cells around them, the normal cells around them, yet they themselves resist dying. That led us to ask, do senescent cells have pro-survival networks that defend them against the things they're using to kill the cells around them? In other words, are they like cancer cells, like B lymphoma or certain kinds of leukemia cells that kill cells around them but survive, and do so because they have pro-survival networks? So based on transcriptomic and proteomic data, we look for survival networks using bioinformatics approaches, and we found indeed that there are what we call SCAPs, or senescent cell anti-apoptotic pathways. We found 5 of them originally. Now there are about 9 of them that are known. So there's a network of pathways that senescent cells use to defend themselves against the things that they're killing cells around them with, to prevent them basically from, that senescent cells use to prevent them from committing suicide. So we used RNA interference approaches to interrogate this SCAP network and ask, if we knock down particular nodes on it, would senescent cells die while non-senescent cells would not die? And we found that was the case. We found in human senescent cells that the exact pathways and nodes that had to be hit depended on the senescent cell type as well. So there's a network. These pathways are in some cases redundant. And the need would be to target a range of these pathways in order to selectively kill senescent cells so they couldn't defend themselves with another pathway. And it also means that some kinds of agents you'd anticipate would kill some sorts of senescent cells and others would not. We again went back to the computer and asked what drugs there are that are in clinical use or are natural products that would target the SCAP network in such a way that we could selectively kill senescent cells. And we predicted, we came up with a list of around 30 drugs off these, using these bioinformatics approaches. They all turned out to be senolytic, but we focused initially on drugs that have a short elimination half-life, that have a history of human use, or that could be used in clinical trials. And we predicted that the drug dasatinib, which is used for treating certain kinds of leukemias, lymphomas, and some skin diseases, it's a tyrosine kinase inhibitor. We predicted it would kill senescent but non-senescent human preadipocytes. And we predicted that quercetin, which is a flavonoid which makes apple peels taste bitter, would kill senescent human endothelial cells, but not non-senescent human endothelial cells. And that turned out to be the case. So we combined these two agents and found that we could kill both cell types. And indeed, we could kill some cell types that neither agent on its own would kill because these networks are redundant. This is what this combination of agents targets. Since we developed those agents, we and others have developed many more using the hypothesis-driven approach that I mentioned. Now, we with collaborators at University of Minnesota have developed high throughput screens for searching for small molecule senolytic drugs, and other approaches, including immunomodulators, vaccines, CAR T approaches have been developed. So we found that this dasatinib and quercetin combination would selectively kill transplanted light-emitting senescent cells from mice, while if we transplanted non-senescent cells, those cells were not killed by administering these agents orally to mice. We found if we took adipose tissue explants, like from that obese woman that I showed you earlier with the diabetes, that have senescent cells in them, we could add these agents for a very brief period of time. It only takes 2 to 3 hours of exposure, and that would initiate the process of apoptosis in senescent cells. They basically kill themselves in about 18 hours. So a 2 to 3 hour exposure will initiate the process. We can remove the drug. They continue to die after that, and it takes 18 hours for them to die. This just shows that in these adipose tissue explants taken from the operating room and put in culture for a couple of days of human tissues, were able to selectively kill senescent cells. We found in obese mice who, much like that woman that I showed earlier, have senescent cell accumulation. We're able to eliminate senescent cells. We're able to alleviate peripheral glucose resistance, or insulin resistance, I should say, and we're able to improve peripheral insulin sensitivity by clamp studies and reduce complications of diabetes and so forth. We found that in those transplanted animals that had frailty, we're able to alleviate their frailty. They had improved grip strength and gait speed. In old mice with frailty, we find that intermittent administration of senolytics 1 day out of every 2 weeks for 4 months is sufficient to reduce their frailty. So senolytics can be given in a hit and run manner because it takes, as I mentioned before, 10 days to 6 weeks for new senescent cells to form. That's why we pick drugs with short elimination half-lives, so we could give them as a bolus and then wait until new senescent cells form before they have to be given again. So these agents do not have to be given continuously. They're eliminated from the body quickly, and this is a way of reducing off-target effects. We're able to increase median lifespan in these animals by delaying all disorders that are related to death in mice. And many chronic conditions in mice we've been able to alleviate with these agents, including chronic viral infections and things like dementias and cardiac dysfunction, lipodystrophy, a long list of other things. So we've established a network across the country, the Translational Geroscience Network, including the institutions I've listed here, where we are testing not only senolytics, but other drugs that target fundamental aging processes in clinical trials. And we're trying to do these trials in parallel, and we're trying to look at serious age-related conditions for these trials. With respect to senolytics, there are now around 20 clinical trials underway. I've listed a few of them here. I'll go into a bit more detail over a couple more slides. But we have trials underway for elderly women with frailty. We have trials underway to try to modulate progression of Alzheimer's disease, to alleviate dysfunction and chronic kidney disease, to reduce inflammation and insulin resistance and complications of diabetes, to administer to people who've had to receive bone marrow transplantation to try to prevent or alleviate the accelerated aging-like state these people often develop 3 to 5 years after a bone marrow transplant. We have trials underway with St. Jude Children's Cancer Hospital to try to alleviate the long-term side effect of chemotherapy and radiation as children, when people, when they're 35 or 40, are dying early of Alzheimer's disease, diabetes, they become frail, they're getting osteoporosis, and they look like they're 70. So that's because radiation and chemotherapy can induce cellular senescence. We have trials underway for idiopathic pulmonary fibrosis, osteoporosis, age-related osteoporosis, osteoarthritis, and a number of trials underway for complications of coronavirus infection. In one of the first clinical trials, we just looked for target engagement. We did biopsies of fat tissue of obese diabetic individuals at day 0, gave them 3 days of treatment with dasatinib and quercetin, stopped the drugs. The drugs are gone by about a day and a half after that, and then re-biopsied them at day 14. And we found we were able to reduce P16 positive cell abundance, SA beta gal positive cell abundance. We were able to reduce macrophage infiltration into adipose tissue and inflammation, and we were able to reduce fibrosis. We also reduced circulating markers of senescent cells. And I note that many of these circulating markers are the kinds of things that you see with frailty in people with chronic HIV. We found in idiopathic pulmonary fibrosis in a very early open label trial, phase 1 trial with, just using people as their own controls, that we were able to alleviate frailty with a short course, 9 doses of senolytic drugs over a 3-week period when we looked at these people 5 days after the last dose, because we know that idiopathic pulmonary fibrosis is a disease that's driven by cellular senescence in the lungs. As I mentioned, we have trials underway for Alzheimer's disease, where we're looking at multiple pillars of aging in subjects with moderate Alzheimer's disease treated intermittently with dasatinib and quercetin in a target engagement trial where we're looking in blood and cerebral spinal fluid for markers of senescence, because we know senescence is associated with Alzheimer's disease, particularly in the hippocampy and frontal lobes. We have a trial underway for age-related osteoporosis, comparing 2 different senolytic regimens, dasatinib and quercetin on the one hand with fisetin on the other. I mentioned the childhood cancer trial. We found that these people who develop frailty after childhood cancer treatment have accumulation of senescent cells. So in that trial, we're comparing again 2 different senolytic regimens given intermittently to see if we can reduce frailty. We're underway, we have trials underway to try to rehabilitate organs transplanted from old into young individuals, kidneys and livers. At this point, we're just treating the organs and seeing if we can rehabilitate them, because we know that if we transplant organs from old to young people, we actually have evidence now that we spread senescence to the young recipients. We have trials underway for coronavirus. It's people with chronic disease and who are elderly who tend to get the worst complications of this. And in preclinical studies, we found we're able to prevent the exacerbation of the SASP and spread of senescence with senolytics in coronavirus-related infections. We have another trial beginning that's going to be across the country for people with coronavirus and potentially long hauler syndrome in nursing homes. So in conclusion, the target of senolytic drugs is senescent cells, not a single molecular pathway. Where we find, I didn't have time to go through it, that we're able to alleviate progenitor dysfunction. We reduce tissue inflammation. Intermittent treatment may be as effective as continuous treatment to reduce side effects and off-target effects. In mice, it's looking like we can delay or alleviate multiple chronic conditions and enhance health span, but we don't know yet in humans. So there's really no place for these drugs outside of the context of carefully controlled clinical trials. People should not be buying these drugs and physicians should not be prescribing them. We need to do clinical trials. And I'd suggest that one area that's going to be important for clinical trials are some of the syndromes associated with HIV infection, including frailty. So I'll just conclude by thanking a huge number of people who are working both across the United States and internationally with us on not only senolytic drugs, but other kinds of drugs like metformin and the rapalogs that target fundamental aging processes. And I wanted to thank you very much.